but just to give you guys a general idea. So kind of the big things for not doing like blocks and spinals and all that stuff. So obviously the patient doesn't want it. If there's an infection where we're doing the injection, if they're on real powerful like blood thinners, or have some weird coagulopathy, and then if they have a pre-existing nerve injury. So sometimes like on these humerus fractures, they can get like a radial nerve palsy and they can't, give a thumbs up or something like that. Sometimes we won't do a block if that's the case. But again, a lot of it's risk benefit, and if something comes up where you have any questions, just let us know and we can kind of go through what blood thinners they're on, nerve injuries, all that stuff. And then you guys are probably pretty familiar with what we've already got. We have the ultrasound machine that most people in the group use, obviously the block cart, and then the different local anesthetics. So it's usually either going to be 0.5% bupivacaine, ropivacaine, or 1/4% bupivacaine, or 0.2% ropivacaine. Usually for blocks, we don't use lidocaine just because it's so short acting, and since they're for kind of post-surgical pain, we like them to be a little longer acting, like Ropiv or Bupiv. And just kind of a checklist for what to do. And this is for a peripheral nerve block. So, do a timeout. One thing that actually is real helpful is knowing how much local the surgeon gave during the case, and that kind of helps us dose how much we're going to give, just to make sure we don't, overdose bupivacaine and cause what we call LAST, or local anesthetic systemic toxicity, and we'll talk about that in a sec. Yep, and like I said, most people use the ultrasound. Some people will use a nerve stimulator with that as well. Everyone's a little different. And then typically, once we're started, needles in, what we'll typically do is give 5 cc's of the local at a time. Again, this is for the peripheral nerve blocks. Just gently aspirate 5 cc's. Some people kind of move the needle around throughout the nerve block. Some people just keep it there. And yeah, usually most nerve blocks are between like 15 and 30 cc's of that local anesthetic that we give. So a lot of like PACU stuff to look for. Obviously there's like long-term nerve injury risk and all that stuff, but you guys aren't going to be dealing with that. So one big thing is, let's say the patient got a lot of narcotics. You still can't control their pain. You can't control their pain, especially, you've got them loaded up with a few milligrams of Dilaudid, and then you do the nerve block, you take away all their pain, and then all of a sudden the pain that was stimulating to breathe isn't there anymore. So just something to kind of look for if they've got a lot of long-term or longer acting narcotics on board. Usually not a problem, but just something to kind of look for. And then this thing called the LAST. Is the block cart around?
Yes.
So this is when either, even if it doesn't go in a blood vessel, if you give way too much local anesthetic overall into your body, so let's say the surgeon gives 60 cc's of 0.5% bupivacaine, and you give 40 or 50 cc's of 0.5% bupivacaine. Even if it doesn't go in a blood vessel, they can still have a bad reaction to that. Or if you give a normal dose, like 20 or 30 cc's, but it all goes into a blood vessel. I'm not going to go through all this stuff, but there's like central nervous system problems where they can have seizures, like a metallic taste in their mouth, kind of just weird CNS stuff. And then obviously the stuff that can kill them. So one of the big things is it can bind to bupivacaine, or ropivacaine can bind to the cardiac receptors and cause arrhythmias and complete cardiac arrest. So that's probably the biggest thing. And again, a normal dose that doesn't go into a blood vessel is very unlikely to cause this. And again, probably the biggest risk that while we're doing the blocks to reduce it is just gently aspirating and make sure no blood comes back, and that lets us know that we're unlikely to be in a blood vessel. But despite all precautions, if they do, go into cardiac arrest or accidentally inject it into a blood vessel or something like that, this kind of just goes through all the stuff. A lot of it's basic CPR, but one big thing is in the bottom drawer here. There's basically TPN or intralipid, and this there's a bunch of different theories how it works, but basically kind of sucks the bupivacaine off the cardiac tissue, and basically helps that, makes it more easy with CPR to get the heart restarted. You know, don't worry about the dose. It lists like all this dose guidelines and stuff. But the main thing is just to start getting a bunch of this on board. For a healthy adult, you know, you could dump the entire bag in and it wouldn't be a problem. So, yep. Again, this is in the bottom of the drawer. Probably that and high quality CPR are two of the best things to do for that. And then, yeah, again, it gives a bunch of different guidelines. All right. So then the different types of blocks, you know, a lot of the arm blocks. So for the shoulder, humerus fractures, distal radius fractures, we do these brachial plexus nerve blocks. So that's like an interscalene, supraclavicular, infraclavicular. Probably the big thing with PACU is this phrenic nerve paralysis you can get. So that's where one of their diaphragms gets numbed up from the nerve block. Usually not a problem. Some people might feel like it's a little weird to take a deep breath. If they're super morbidly obese or something like that, or have bad lung disease already, then they can have problems with O2 sats and all that. So something to look for. Usually supplemental oxygen is all it takes, and if they're being admitted overnight, not a big deal. But occasionally, especially, you know, at the outpatient surgery centers, if we do one of these and maybe they have some lung disease that's not in their history we don't know about, very, very occasionally we'll have to admit them overnight because their O2 stats kind of drop and we can't get them off the O2 and send them home. And then when the block wears off, everything goes back to normal. You know, and this is just kind of what we're numbing up here. All the nerves coming out the spinal cord, and then these are just different places along it that we inject the local. Tap blocks for abdominal surgery. I feel like we used to do them a decent amount, and then all the surgeons kind of started doing their own in the ORs. I don't know. Do a lot of people do tap blocks anymore in PACU?
No.
Yeah, and so something that, yeah, I think all the surgeons kind of learn that technique intraoperatively. So in OB, we still do them a decent amount, but yeah, not a ton here. But there is just 2 injections in the belly, and that kind of covers like abdominal wall pain. The sciatic block, typically like the ankle fractures, we'll do them for usually in the back of the leg between like the like gluteal fold and the right behind the knee, somewhere along there, and that numbs everything up. A lot of times they can't move their toes, can't feel anything, and gets rid of almost all the pain with an ankle fracture. Let's see, femoral blocks. Do people do many of those here? Yeah, that with this adductor canal block, that's typically what we'll do instead of a femoral for after ankle surgery, and that numbs up. Like the sciatic gets 80 to 90% of the pain in the adductor canal, especially if they have an incision on the medial side of their leg or medial malleolus. Will do that, and then that pretty much gets rid of all the pain from an ankle block. Any questions about all the peripheral blocks that we do, or like how we do them, or different preferences or anything? Yeah. For those who just walked in, there's gummy bears and bagels over there. Try and bribe people into being excited about regional anesthesia. So spinal anesthesia,